Today's lecture is on endocrine imaging. Now, the usual idea about endocrine diseases is that we do not require imaging during the course of their diagnosis and treatment, but this cannot be further from the truth because in reality, for most of the endocrine diseases, not only we need imaging for the confirmation of the disease, we require it for its detection and for the evaluation of the treatment that precedes after the diagnosis. So, endocrine imaging is both a new emerging subspecialty and it's also very important for any practicing doctor to have sufficient knowledge of it. So, we'll start our lecture on endocrine imaging with osteoporosis and Paget's disease. Now, surveillance of mineral density in postmenopausal women and elderly men is a must. Why? Because both in an elderly man and postmenopausal women, the loss of mineral density in bones is a given. It happens to every patient. So its surveillance, its constant monitoring must be done. So what is osteoporosis? Osteoporosis, like I said, is a gradual loss of mineral density in bones, especially in the long bones. But it doesn't happen right off. It's a very gradual process. Now, what happens is that first of all, we get osteopenia, that is the loss of some of the mineral density of the long bones. Now, there are two images here of long bones. Now, as you can recall from your anatomy, that long bones are usually comprised of two structures. One is the cortex that covers the bone, other is the medulla. Now, the cortex of the bone is of the highest strength. It is of compressed mineral, but the medulla of the bone is both extremely porous. It has a lot of cells in it because it has to accompany a lot of bone marrow, a lot of vasculature. So the outside of the bone, the cortex, is always hard, dense, but the inside of the bone is porous because, again, like I said, it has to accumulate a lot of bone marrow and a lot of vasculature. But as with the age, with the women who are postmenopausal, elderly men, usually after the age of 50 or 55 years old, what happens is that there is a loss of mineral density, and that starts with osteopenia. Now, this is an example of an osteopenia where the cortex is intact, but the medulla, the inside of the bone, is starting to lose its mineral density, and you can easily see these small structures, these holes in the medulla, which compromise its integrity, its strength. Now, if osteopenia goes unchecked, that develops into osteoporosis. Now, osteoporosis is a disease where the bone lose all of their strength and they usually result in fractures. And those fractures are not simple fractures. Sometimes they are compacted, sometimes they're compound fractures. Whatever the cause is, an osteoporotic fracture is always a complex fracture. So, treatment of osteoporosis must be commenced if it is found, but in all likelihood, any osteoporotic event must be avoided. and it can be avoided if you surveil, if you constantly monitor your patient that he or she does not develop any kind of osteoporosis. Now, I also mentioned another disease called Paget's disease. Now, in osteoporosis, what happens is that first we get osteopenia, that there is some loss of bone mineral density. Then there's huge loss of bone mineral density, which results in osteoporosis, like the name indicates. Osteo, bone, process, pores, like there's a lot of pores inside the bone. But the Paget's disease is a focal disease. It happens at the focal areas of the bone. So, if you ever encounter a patient with a global loss of bone mineral density, usually it's either osteopenia or osteoporosis. But if the loss is focal, either it's a tumor, there might be some malignant problem with it, it might be some kind of infection like osteomyelitis, or it might be Paget's disease. Now, what happens in Paget's disease is that the cortex or the outer area of the bone is compromised. The osteoclastic and the osteoblastic activity is totally destroyed. It is disarranged, and that results in a particular image, in a particular style, that a lot of tuberculi and a lot of different objects or protrusions start to appear on the bone. Or in simple terms, the cortex of the bone starts to thicken at certain points. Now, this is a paradoxical event. You might think that thickening of bone at certain areas increases its strength, but this does not happen for two reasons. One, the thickening of the cortex, which results in protrusions and tuberculi, is not uniform. Now, because of this non-uniformity, the areas which there's thickening, they start to bear less and less weight, and the areas with normal thickness start to bear more weight, and this results in the breakage of the cortex of the bone. So, in Paget's disease, because of the non-uniform thickening of the cortex or in the focal areas, results in the less strength of the bone, and this is usually observed in patients. It is also an hereditary disease, and it's a disease that must be treated, must be diagnosed, and must be immediately treated for the patient before any kind of a complex fracture happens. Now, next is the choice of modalities. Now, whenever we encounter a patient with osteoporosis and Paget's disease, the choice of modality is very important. Now, the first choice of modality is a DEXA scan or a dual energy X-ray absorptiometry. Now, DEXA scan is a very specialized modality where X-ray are bombarded on the patient, and their absorption ratio is measured in not percentages but in standard deviation. Now, this absorptiometry event gives us two kinds of scores. One is called the Z score or the Z score. The other is called the T score. Now, Z score is the score of the patient, that is the standard deviation of that patient from her or his own cohort, that is his own sex and age. But the T score is the value, that is the standard deviation from the patient's mean from those patients which are younger. So the T score is basically a comparison of that patient to those patients which have a normal absorptiometry pattern. So what we usually do is that we read the T score, because in T score the comparison is being done with the patients who have normal bone structure. The Z score gives us the values where the comparison is being done with the patients who lie in the same cohort or in the same group, in the same sex, in the same gender and age. So a T score of from -1 to -2.5 indicates osteopenia, that there is a loss of bone mineral density. And a T score of less than -2.5 indicates osteoporosis, that that patient has now developed porous bones which are now prone to fracture. Next modality that we might use is called a quantitative CT scan. Now, quantitative CT scan is not preferred to DEXA scan. The first reason being that DEXA scan gives us a lot of information, and that information is very helpful for the patient for his or her treatment, in order, if she has already a fracture, how to treat, what is the extent of the disease. All of those information can be achieved from DEXA scan. The second reason is that quantitative CT scan gives us the bone mineral density of spine. And the third and the most important reason that we do not use a quantitative CT scan is that because of its harmful nature. Even though DEXA scan also uses X-rays, CT scan uses way more X-rays than a DEXA scan. So it's more harmful because of its ionizing property. Another modality that we might use is a lateral spine radiograph, a simple lateral X-ray radiograph of the spine or the bone in question. Now, this is a very simple technique, and it is usually reserved for those patients who cannot undergo either the DEXA scan or the QCT, and it is usually done for the older patients. Last modality that we use is the MRI. MRI has the property of confirmation. Now, whenever we suspect any osteoporotic or Paget's disease in a patient, a lot of information can be gained from these first three modalities, but the disease itself is confirmed only after the MRI. Now, that MRI can be both enhanced or unenhanced depending upon the situation, but MRI in this situation is usually reserved for those patients where we have to confirm the disease, or those who cannot have the first three modalities. Next, we have an anterior posterior radiograph of a patient with Paget's disease. Now, here you can easily appreciate that patient's right hip bone is normal. It has normal contours, normal ilium, ischium, normal head of femur, but on the left side, the patient is exhibiting a lot of non-uniform densities, which are all over the ileum of the patient. Now, these are what we called abnormal tuberculi, and these abnormal tuberculi are the hallmark of Paget's disease. So, any patient with this kind of picture is usually indicative of Paget's disease. For such kind of patient, usually the choice of modality starts with first with a DEXA scan, then to the quantitative CT scan, then if the patient is old, such as in this case, a normal radiograph, and then the patient will go to a PET CT scan. A PET CT scan is done because of a lot of reasons, and it will be discussed in further down the lecture. Now, this is a coronal CT scan of a patient with Paget's disease. Again, you can easily appreciate that the right side of the patient is normal. It has normal medullary area, it is uniform, it has normal cortical area, but the left side of the patient, now this is showing a very abnormal picture because there are a lot of increased density of the patient, because the increased density of the bone should only be along the cortex. Here it is inside the medulla, it is outside the bone, it is resulting in these thickened tuberculi, these protrusions, and this type of picture is a hallmark, is pathognomic for Paget's disease. Now, next is a radionuclide bone scan. Now, like I said, whenever Paget's disease is observed in any patient, radionuclide bone scan must be done. Why? First of all, it is done in order to measure the extent of the problem, because both the DEXA, the quantitative CT scan, and a normal radiograph will not give you the extent of the damage the Paget's disease has done, but the radionuclide bone scan will give you how much Paget's disease has advanced, where it has advanced, how much invasion it has done. All these information can be extracted from a radionuclide scan. Now, this is a picture of a person with a radionuclide scan. As you can easily see here that this person has a compression fracture. Now, because of the compression fracture, there's increased density of bone here. Then we have the urinary bladder. Now, urinary bladder is showing increased uptake because the radionuclide that we have introduced in the patient is being excreted through the urinary bladder. That's why it's showing. And this here is the Paget's disease. Now you can easily compare it with the right side. It's normal because you can easily see the wing of the ileum. It is more thick, it is showing a bit more darker color, but the Paget's disease on the left side is extensive, but it is only limited to the hip bone. It has not invaded the femur or the head of the femur. It has not invaded into the vertebra. So this patient has Paget's disease in his or her hip bone. So the information given on radionuclide scan is very clear. Now, next topic is the lateral radiograph of a person. Now here, this is a normal radiograph of a forearm of a person, and the projection is lateral. Now here you can easily see that there is an incomplete fracture because of the thickened cortex. Now, as I mentioned earlier, that Paget's disease results in non-uniform thickening of cortex of bone. And it's a paradoxical event because thickening of cortex actually results in weakening of the bones. And this is a very good example of the stress fracture the patient has suffered. Because of this thickening of the cortex right here, this area has suffered more um, pressure or more tensile strength than it is able to withstand. And because of that, this person has undergone an incomplete stress fracture. So, in Paget's disease, along with tuberculosis and protrusions, we also see incomplete fractures, which are termed as stress fractures, because of the non-uniform protrusion and tuberculosis that the Paget's disease exhibits. Our next topic is thyroid and parathyroid dysfunction. Now, thyroid and parathyroid gland lie in the neck region, anterior to both trachea and esophagus. Thyroid gland is the larger gland, and parathyroid gland resides in the parenchyma of the both lobes of the thyroid gland. Now, any dysfunction with thyroid or parathyroid gland results in either hyperthyroidism or hypothyroidism. For hyperthyroidism, the most common cause is the Graves' disease. And Graves' disease is usually accompanied with both the ophthalmopathy, which is usually termed exophthalmos, and it is also accompanied with dermatitis or the dermopathy. One of the more less common cause of hyperthyroidism is a multinodular goiter or a functional autonomous nodule. Hyperthyroidism transiently at the start also occurs during the Hashimoto thyroiditis and the subacute thyroiditis, and it may also occur during the pituitary adenoma, but this is very rare. The common culprits for hyperthyroidism are usually the Graves' disease, the Hashimoto thyroiditis, only transiently, and sometimes the multinodular goiter or an autonomous functional nodule. As for the hypothyroidism goes, it is usually diagnosed and confirmed clinically via the physical exam and the lab reports. Imaging is usually not required during or for the hypothyroidism. Now, for the parathyroid gland, as for the hyperthyroidism, one of the most common cause which results in hyperparathyroidism is hypercalcemia, and hypercalcemia results. The most common cause is a parathyroid adenoma. So, for all of these diseases, in order to either confirm them or to diagnose them, or if even we have suspicion due to the lab reports and physical exam, the choice of modality is very important. So, the first choice of modality is an ultrasound. So, for the thyroid, ultrasound is the gold standard. Why? First of all, it is quick, it is reliable, it is portable. Second, it has very good penetration inside the neck, because neck has a lot of structures, a lot of vasculature. So whenever there is a dysfunction with the thyroid or parathyroid gland, ultrasound usually picks up the problem. Either it's hypothyroidism or hyperthyroidism. Another modality that we might use is Doppler imaging. Now, Doppler imaging is a subtype of ultrasound where we actually measure the velocities of blood inside the arteries and veins, and it is usually done in patients with goiter or Graves' disease in order to check the vasculature of the thyroid or the parathyroid gland, because that might give us some clue as what kind of disease the patient has. Another modality that we use is a radionuclide thyroid scan, or simply called a thyroid scan. Now in thyroid scan, what we do is that we introduce small amount of iodine 123, which is radioactive. That iodine is then taken up by the thyroid gland, and then a series of images through the gamma camera is taken. Now the uptake of the iodine is indicative of how much the thyroid is functioning. Last but not the least is the MRI. MRI is done because again, neck is a very complex structure. There are a lot of structures going through it, around it, in it, and because of this, we need a modality which has higher resolution, which has higher levels of both phases and windows, and because of this, any problem with the neck or for thyroid or parathyroid in particular can be picked up in order to confirm it with an MRI. CT scan is usually not done because again of its harmful nature, because of its X-rays which are ionizing radiation. Now here is an example of a patient with a thyroid scan. Now thyroid scan again, like I said, is a radionuclide scan where we introduce a radioactive iodine inside the patient. Usually what happens is that we get for a normal patient an image like this where there's regular uptake of the patient, but sometimes we also get background tissue during the images obtained through the gamma camera. So this is a normal thyroid scan of a patient. Next, we have an image of a patient which has hyperthyroidism. As you can easily see, the thyroid uptake of this patient is, well, more than recommended. It is more than 50%. And even with it, the thyroid uptake is so less. There you can not see any uptake. There are a lot of whiteness in this image. The more the whiteness in a thyroid scan, meaning there's less uptake for that patient, and because of this we can easily assume that this patient is undergoing hyperthyroidism. Now what might be the cause of that hyperthyroidism? That is a question which is answered by the physical exam and the clinical examination and lab reports. Another, like I said, ultrasound is usually the first choice that we used for thyroid and parathyroid scanning. Now, if we use a thyroid scan, it is usually done in a transverse fashion, that the probe is usually lies along the plane, perpendicular to the plane of the thyroid gland. In this picture, this ultrasound of the thyroid, you can easily appreciate that this is the right carotid artery, this is the trachea, and this is the thyroid gland. Now, extent of the thyroid gland should be around here. This extension of thyroid gland anteriorly gives us that this patient is undergoing what is called a goiter. Goiter is what we call the enlargement of the thyroid gland, and goiter can be due to both hyperthyroidism and hypothyroidism. So, if we use an ultrasound to diagnose a patient with thyroid or parathyroid dysfunction, this is a typical image that we usually get if he or she has goiter. Our next topic is adrenal dysfunction and tumors of pancreas. Now, in order to understand the adrenal dysfunction, we have to understand the anatomy of the adrenal glands. Now, adrenal glands are also called suprarenal glands because they lie superior to the kidneys. Now, because kidneys are present in our body in pair, adrenal glands are also present in a pair, and they lie superiorly to the both of the kidneys, but they lie inside the renal fascia or the Grotte's fascia. Now, because of this, one might consider that might be part of the kidney, but they are not. They are not part of the kidney, they are actually part of the reticuloendothelial system or the RES. And as for the pancreas, pancreas is a single organ which has both the endocrine and the exocrine function, and it lies between the both kidneys. This anatomy is very important. Why? We will learn this down the lecture. Now, this is an image of a contrast enhanced CT scan. Now, carcinomas of adrenal gland are very, very rare. What we usually find in adrenal glands are adrenal adenomas. And because of adrenal adenomas, they might exhibit problems relating to such as Cushing disease. Carcinomas, even though they are rare, they are present. And one example is a pheochromocytoma. In pheochromocytoma, what happens is that there is excess excretion of catecholamines, and because of this, the patient undergoes hypertensive episodes. But on CT scan, both adenomas and carcinomas have very different picture. For an adenoma, it presents like a homogeneous lipid containing solid mass. For a carcinoma or a pheochromocytoma, it presents like a normal carcinoma with its infiltrative properties. This contrast enhanced CT scan has a solid mass which lies superiorly to the kidney inside the adrenal gland, and we can easily say that this mass is an adrenal adenoma. Now, if we perform an MRI or we have some kind of suspicion that the patient does not have adrenal adenoma, he or she might have carcinoma or pheochromocytoma, what we do is that we perform MRI. And for this particular case, we perform a special MRI with a particular phasing property in which we phase in and phase out the properties of the tissue. Now, in this first example, you can easily see that in phase, the mass is round, it has discrete, uniform edges, it has uniform, homogeneous parent tissue inside it. But when the image is taken out of phase, again it has the same roundness, discreteness, homogeneous inside the mass, but it is of more darker nature. Now, because it is has a more darker nature to it, we can easily assume that this is a lipid containing mass. Now, because we know that adrenal adenomas are lipid containing, we can easily confirm that this mass is an adrenal adenoma. There is a certain term in radiology which is termed as incidentinomas. Incidentinomas are those findings which are usually not intended, which are just found by chance. Let's say a patient is undergoing a contrast enhanced CT scan for suspicion of adrenal adenoma. But along with that adrenal adenoma, the patient also has some kind of mass inside his or her pancreas. And that mass inside the pancreas is usually an ensilinoma. So the discovery of a tumor inside the pancreas, when we were actually going to look at the adrenal glands of that patient, is what we call an incidentinoma. There are other examples of incidentinomas like a gastrin secreting tumor, when we are actually going for gastric carcinoma inside the stomach. There are a lot of examples for it. So incidentinomas are common. They usually happen by luck, but they must never be overlooked. If the patient has both the adrenal adenoma and the insulinoma, patient must be treated for both, and the treatment for both, the further treatment plan, the guidelines along with it should be followed. Our last topic in this lecture is pituitary dysfunction. Now, in order to understand the pituitary function, again, we have to revise the anatomy of the pituitary gland. Pituitary gland is also called the master gland of our body. Why? Because the hormones that it secretes are those hormones which controls almost all the functions of our body, from growth to reproduction to adrenal hormones to thyroid controlling hormones. A lot of function, some say all of the function of the body is controlled through the pituitary gland, and pituitary gland lies both anterior and inferior to the human brain. It lies superior to the ethmoid bone and lies inferiorly to the both optic chiasma and the optic nerve. Now, the mentioning of the optic chiasma or the optic nerve here is important because any mass inside the pituitary will place pressure on both the optic nerve and the optic chiasma, and this will happen vice versa. Any mass or protrusion inside the optic nerve or chiasma will result on the pressure on the pituitary gland, and this will result in certain problems. Now, pituitary adenomas are usually classified as either microadenomas or macroadenomas. Microadenomas are those which have a diameter of less than 1 centimeter, and macroadenomas are those which have a diameter of more than 1 centimeter. Usually about 20% of all microadenomas are non-functioning, that they do not have any symptoms and they are usually left alone. They are left alone because of the complex nature of both the pituitary gland and its location. But if it's causing problem, it has to be dealt with either medically or surgically. This is an example of a patient with a macroadenoma, because you can easily appreciate that beneath this optic chiasma, the pituitary should be of this size, but it has enlarged so much that it is more than 1 centimeter. So this is a macroadenoma, and this adenoma must be removed surgically because it will start to create problems. Now, one of the most common adenomas that we find in a pituitary is a prolactinoma, which secretes prolactin hormones. But other adenomas are also present, though they are rare, but they are present, like growth hormone secreting adenomas. There are others like both TSH, FSH, LH secreting adenomas. Even though they are rare, they're still present, and there might even be adenomas which might secrete more ADH or oxytocin, though it is extremely rare and it only happens when there is a rupture of the posterior lobe of the pituitary gland. Again, this is a contrast enhanced MRI of a patient which has a pituitary adenoma. Now you can easily see that this is a hypointense cystic area. Now pituitary adenomas sometimes are complex masses, that they have both cystic properties and solid properties. They are of complex nature, and whenever something has a complex cystic nature, the malignant potential of that cyst increases, and it increases many times. So in this particular patient, as you can easily see, because of this complex cyst with both the solid part and the cystic part, the optic chiasma has both been invaded, infiltrated by this mass. And because this mass is more than 1 centimeter, it is 1.6 centimeter in, it is a macroadenoma. Now, another peculiar quality of pituitary adenomas is that they are hypointense. Now, what we mean by hypointense is that they themselves have a less reaction to the magnetic resonance, but the tissue around them has an enhancing effect. So this type of behavior of pituitary adenomas is what is called an hypointense lesion, where the lesion itself is hypointense, but the tissue surrounding it is hyperintense. So in this lecture, we learned about the osteoporosis and the Paget's disease. We learned when osteoporosis becomes important, like in the elderly men or the postmenopausal women. We learned what is the difference between osteopenia and osteoporosis and how they have a global presentation. We learned about the diseases which have a lytic or a focal presentation, such as a tumor or an infection or Paget's disease. We learned what is the difference between Paget's disease and other focal diseases, how they present on different modalities. Then we learned about different modalities and our choice for them, what is a DEXA scan, why DEXA scan is used, what is a T-score, what is a Z-score, why we use T-score, not the Z-score during the DEXA scan. Then we learned about the quantitative CT scan. We learned about the plain lateral spinal radiographs, which is usually done in the older patients, and then we learn about the MRI, because MRI is used to confirm any suspicion that we might find in all these other modalities. Then we learn about the thyroid and the parathyroid gland. We learn that thyroid gland lies in the neck, anterior and lateral to the trachea and esophagus. Then we learned about the parathyroid gland. We learned about the different states of these glands which results in their dysfunction, such as hyperthyroidism, what causes hyperthyroidism, such as the Graves disease, Hashimoto thyroiditis, subacute thyroiditis. We learned about what is a hot nodule, what is a cold nodule. We learned about the hypothyroidism, how imaging is usually not required in hypothyroidism unless the patient is exhibiting or presenting with a goiter. Then we learned about the hyperparathyroidism, and we learned about the both thyroid scan and the parathyroid scan. We learned that we use iodine in the thyroid scan, and we use technetium, which is highly sensitive and specific for the parathyroid gland. Then we started to learn about the adrenal gland and its dysfunction. We learned the anatomy of the adrenal gland, that it is a suprarenal gland, but it lies inside the renal fascia. Then we learned about what might happen if there is adrenal dysfunction. There might be an adrenal adenoma, there might be an adrenal carcinoma. What is the difference between an adrenal adenoma and adrenal carcinoma? Because an adrenal adenoma contains a homogeneous lipid containing mass, while carcinoma has more of a soft tissue nature to it. Then we also learned about pheochromocytoma, why it is important and categorized in the carcinoma. We learned about the incidentinomas, that these are the findings that are usually found by luck. When, for example, we are trying to find out that what is wrong with the adrenal gland, but instead of the adrenal gland, we find that there's something wrong with the pancreas, that there is an insulinoma that is present inside the parenchyma or the beta cells of the pancreas. So such findings, which are not intended but are found on different radiographic modalities, these are called the incidentinomas. Another example might be a gastric secreting tumor, which might be found when we are actually looking for a gastric carcinoma during the Zollinger-Ellison syndrome. Lastly, we learned about the pituitary dysfunction. What is a pituitary gland? Why it's called the master gland? What are its different lobes? The anterior lobe, the posterior lobe. We learned that prolactinoma is the most common adenoma of the pituitary gland, but adenomas secreting both the growth hormone are also present. We learned that those adenomas which secrete the FSH, LH, and TSH, even though they are extremely rare, they are still present and you might find them. Then we learned about that what is the difference between adrenal glands anatomy and the optic nerve. What is their correlation? Because mass in a pituitary will compress an optic nerve, or a mass in the optic nerve might compress or dysfunction the adrenal gland. We also learned that in adrenal gland there's a certain terminology, that their adenomas are either classified either as microadenomas or macroadenomas, that is less than 1 centimeter is a micro, or more than 1 centimeter is macroadenoma. Now this classification is important because for microadenomas, about 20% of them are non-functioning. They do not pose any threat. So we learned all of that in today's lecture. So thank you so much for watching sqadia.com.